14-3-3-eta biomarker for rheumatoid arthritis, diagnosis, prognosis, and monitoring. So as you are all aware, this is the landscape for the autoimmune space, specifically rheumatoid arthritis. So there are significant challenges in not only the diagnosis, but treatment and management of RA patients. So there are 50 million Americans that have Alzheimer's disease, and 25% have arthritis from the adults. So there are significant autoimmune and musculoskeletal challenges in today's healthcare. Tucked into these numbers is the 0.5 to 1% of the US population that has rheumatoid arthritis. And so the challenge here is that RA patients, they typically have symptoms that match other musculoskeletal and autoimmune conditions, which makes it difficult to diagnose early. And so what feeds into this is there are 7 million referrals to rheumatologists per year to about 5,000 addressable rheumatologists. So there is a mismatch in need, and research shows that around 50% of the referrals to rheumatologists are incorrectly referred. Once a patient is diagnosed, they have significant challenges in identifying the appropriate therapies, as well as managing the treatments. So out of this, you have around 43% of RA patients, they have to cycle through 3 biologics to identify an effective treatment with manageable adverse effects. And once the underlying disease is managed, 40% will flare within 1 year of remission. So the overarching takeaway is that there are significant gaps throughout the entire continuum of care. And that one tool that can help address this is the 14-3-3-eta biomarker, as it can help assist bridge those gaps and with RA patient management. So this is a multifaceted blood test for diagnosis, prognosis, and monitoring of RA. It is a mechanistic and modifiable biomarker and has utility from pre-RA to remission. So this is just a quick high-level overview of the utility of this biomarker. In diagnosis, it can help detect early RA, which allows treatment within the critical window of opportunity. This is the 6 to 12 week of symptom onset that allows the least invasive therapies that have the most pronounced effects. It can assist with prognosis, whereas serial changes in this biomarker's level can inform joint damage prognosis, and this can help inform treatment decisions along the course of treatment. Furthermore, the 14-3-3-eta biomarker can assist with monitoring, as its levels are closely tied with disease activity. So this can assist with treat-to-target strategies for clinical and radiographic remission. So altogether, this biomarker can help improve clinical outcomes for RA patients. So what is this biomarker and where does it come from? So this is just a picture of a healthy and inflamed joint. On the left, we see that the 14-3-3 superfamily of proteins is a ubiquitous and fairly conserved pool of proteins. The eta isoform is present within the synovial membrane, within the intracellularly specifically. However, through the transition to synovitis and inflammatory arthritis, 14-3-3-eta is externalized into the synovial fluid and blood, where it acts as in an autocrine and paracrine fashion as a pro-inflammatory ligand, where it can upregulate pro-inflammatory pathways that leads to the deposition of pro-inflammatory mediators that can directly contribute to the pathogenesis of rheumatoid arthritis. So what's key here is that in the healthy tissue, 14-3-3-eta should not be present in the blood, and that its presence in the blood signifies underlying joint damage processes. And so because it is a mechanistic biomarker, this allows us to look at 14-3 eta levels pre-disease and identify who's at risk for RA. So this is two studies looking at the upstream effect of this eta biomarker. On the left here, we have patients that have undifferentiated, a cohort of patients that have undifferentiated arthralgia. So this is just joint pain. And what they saw was, and they followed these patients over the course of 5 years. And what they found was that the patients that went on to develop arthritis had 3.4 times higher levels of 14-3 eta than the cohort of patients that went on to not develop arthritis. So this kind of, this research underscores the importance of identifying patients at risk and that this biomarker can be present in the blood years before the clinical onset of disease, which allows for closely monitoring and lower invasive therapies to take effect and potentially change the course of the disease. On the right here, we have a study that looks at the first degree relatives of patients with established RA. So these FDRs are inherently at higher risk for developing rheumatoid arthritis. So they looked at these patients and they measured 14-3 eta levels over the course of 10 years and looked at who transitioned and who went on to not transition to RA and who transitioned to RA. And they found that the transitioners, the relatives that went on to transition to RA, they had higher 14-3 eta levels at baseline, and there was a spike at or around the time of the clinical onset of rheumatoid arthritis, as opposed to the non-transitioners, which had low eta levels at baseline and continue to have low levels throughout the course of 10 years. So the key takeaway here is that looking at 14-3 eta, it can help predict imminent transition to rheumatoid arthritis in at-risk populations, as well as identify at-risk patients prior to disease onset. So let's look at the
with like all the other physicians and practitioners and stuff.
I'm sorry, what was the question?
Sorry about that. It wasn't a question. It was
okay.
Somebody wasn't muted, so.
Oh, good.
Sorry about that. Go ahead.
Okay, so let's move on to the diagnostic value of 14-3 eta. So in the panel here, we have the traditional biomarkers for rheumatoid arthritis, anti-CCP, and rheumatoid factor. And then we also have the additive benefit of adding 14-3 eta to these biomarkers. And as you can see, there is an additive effect of eta to these biomarkers, especially with early RA. So 14-3 eta has the highest sensitivity for a singular biomarker and has a great additive effect to traditional biomarkers. So combining all three increases the diagnostic sensitivity of positively identifying early RA to 78% and 96% for established RA. Furthermore, what's critical here is that 14-3 eta identifies 21% of early RA and 67% of established RA patients that are seronegative for anti-CCP and or rheumatoid factor. So this is a critical population that may be missed by traditional biomarkers. So the key takeaways is that 14-3 eta is the highest sensitivity singular biomarker for early RA at 64%. And with a specificity of 93%, it complements rheumatoid factor and anti-CCP. It can also help capture a significant portion of seronegative RA. And altogether, it can help with earlier and more accurate diagnosis of rheumatoid arthritis to allow for treatment within the 6-12 week symptom onset. So just wrapping up this part of the talk, 14-3 eta identifies at risk and RA patients early and accurately. It is a novel mechanistic and modifiable biomarker that predicts RA development in patients with joint pain and assists with early diagnosis. So positive status can detect disease at a very, very early stage and assist with referral within the 6 to 12 week window of onset, of symptom onset, sorry. And this is the critical window of opportunity. It can help identify people at risk of developing RA, which allows you to follow them before any joint damage occurs. And taken together, this can help prevent disability and irreversible joint damage. So beyond identifying at-risk patients and assisting with early and accurate diagnosis of RA, 14-338 also serves as a powerful prognostic indicator. And so here we have a cohort of 330 newly diagnosed patients. They looked at 14-338 levels at the time of diagnosis. This is the baseline level, and looked at patient remission rates and joint erosion over 5 years, and stratified patients into high and low ADA levels, high being the gray at above 0.5 nanogram per mil, and low of less than 0.5. And so what they saw was that remission rates were lower in patients with elevated baseline 14-338, and in line with that, joint damage and erosion was higher in patients with elevated baseline 14-338. So the key here is that you can help stratify patients into risk categories at the time of diagnosis, and so which allows for closely monitoring and potentially escalating first-line treatment to achieve the successful treatment outcomes. So even in clinical remission, even in clinical remission, 14-338 can predict joint damage independent of CRP and disease activity scores. So this is the exact same cohort of patients as the last slide. And what they looked at is they took another measurement of 14-338 at 18 months post-diagnosis and post-treatment, and stratified patients into disease activity score, active or in remissions, active being red, remission being blue, and also stratified patients into high and low 14-338. High being the solid line and low being the dotted line. And they looked at joint erosion over the remainder of 5 years. So I'll just run through each data point here. So at the top here, we have the red solid line. These are patients that have SDI active disease and high ADA. They did the worst, as you can imagine. They had the most joint erosion for the course of the study. On the bottom blue dotted line here, we have patients that are in SDI remission, and have low ADA. So they had no joint damage over the course of 5 years. This is the lowest risk category. What's interesting is the solid blue line here. These are patients that are in clinical SDI remission, but have high ADA levels. So these patients actually did worse in clinical outcomes than patients in the dotted red line. These are patients that are SDI active, but low ADA. So the key takeaway here is that the 14-338 can identify patients that may have masked or parent remission and underscores ongoing joint damage within these patients. What's critical here is that a major contributor for these disease activity scores is CRP reading. And so this study also concluded and looked at the correlation between CRP and 14-338 and found that they do not correlate. However, they're both independent and uncorrelated risk factors for the progression of rheumatoid arthritis. CRP being overall systemic inflammation and 14-338 being specifically for joint damage. So this study underscores the importance of running 14-338 with all CRP requisitions. And so, especially with the prevalence of these new biologics, specifically the IL-6 receptor inhibitors and the JAK inhibitors, you can have patients that have no CRP, but still have joint swelling and masked joint damage. So this is the importance of identifying a biomarker specific for joint damage rather than inflammation. So moving away from prognosis, because 1433-eta is a modifiable biomarker. It can respond to treatment outcomes. It can be used for treat to target strategies and tight treatment control. So this is a cohort of 149 patients where they took levels of 1433-eta pre and post treatment and saw that a decrease in 1433-eta post-treatment highly correlates with improvements in disease activity scores. So this is DAS, ESR, DAS, CRP, and ESR. And so this, the treatments in this cohort were both biologic and non-biologic DMARDs across various classes of biologics. And so the core here again is that because 1433-eta is closely related to joint damage, you can actually use it to track treatment response to help identify patients that are not responding to treatment a lot earlier than symptom onset. This is another study outlining that 1433-eta monitoring is agnostic to treatment type and can assist with identifying the appropriate treatment. So this is a study of 200 patients conducted with our partners at AbbVie, where they looked at 1433 levels in patients that were taking methotrexate as well as a new JAK inhibitor, UPA. And they saw that levels in 1433-eta dropped with treatment onset, and they correlated with improvements in disease activity scores. And a key takeaway here is that the drop in 1433-eta occurs as early as a few weeks. So it can help really monitor the treatment response at time points that are typically before symptom onset or adverse effects for these treatments. So just wrapping up this part of the talk here, I just want to highlight that 1433-eta is a mechanistic biomarker for joint damage that is directly involved in the pathogenesis of RA and improves the diagnosis rate when added to RF and anti-CCP. So it can help identify patients in the preclinical phase of arthritis. This is the arthralgia at-risk group, as well as the first-degree relatives, as well as it can help accurately diagnose early RA, and is a welcome complement to the current roster of biomarkers. It can help it can identify patients that are also at high risk for progressive joint damage. This is the prognostic utility of 1433-eta, as well as it can help monitor patients that are in clinical remission for underlying joint damage or any upcoming flares. And so this continuum outlines the utility of 1433-eta across the entire patient odyssey and the continuum of care. And so with this, you can identify patients pre-disease, during disease, and you can help monitor the patient response to therapy, as well as keep an eye on disease processes while they are in remission. This is a quick snapshot of the current landscape in diagnostic tools for RA and their clinical positioning. As you can see, 1433-eta occupies a unique position where it serves as a RA screening and diagnostic tool, as well as provides significant clinical utility in the prognostic and monitoring space compared to its counterparts. This is a quick snapshot of our high impact publications that outline the clinical utility throughout the entire continuum of care. And this is just more publications broken down by specific category. So this is the risk of RA development. This is the at-risk and pre-disease groups. This is profile RA profiling and diagnosis. Can also positively identify specific subsets of SLE patients. I didn't get into that, but we can also talk about that at the end. For RA, it is a strong joint damage prognostic indicator. It can help identify high-risk patients that are at the increased risk of radiographic progression, as well as it is uncorrelated with CRP. And this is important as both provide valuable prognostic and monitoring indications for these patients. Finally, it can help with treatment decisions. It can help with remission maintenance and treatment choices for better outcomes for RA patients. These are the last two studies I want to highlight. This is on top year of a 2021 review highlighting the role of 1433-eta. On the bottom, we have a 2022 publication within a practical pain management. Again, highlighting that 1433-eta helps assess the veracity of the diagnosis and severity of early RA. It can be combined with existing biomarkers to stratify patients into more effective treatments and is a welcome addition for diagnostic and treatment strategies. And furthermore, that it is approaching the standard of care for rheumatoid arthritis. And with that, this is my closing slide. How do you order the test? So to answer the question that usually comes up, this is fully covered by insurance. And the test can be ordered through our partners at Quest and LabCorp, either as a standalone test or as a part of panels. And with that, I'd be happy to answer any questions you may have. And this is my contact information if you ever want to reach out regarding anything that I went over through today. Thank you.
Well, thank you so much. Anybody have any questions? Dr. Cruz asked costs, insurance. You said yes.
Yep, fully covered.
What would it cost if, you know, on its own as a standalone?
So as a standalone without insurance, the reimbursement, I think, is around $40, $50. That's as far as we hear from our partners at Quest and LabCorp. However, we haven't gotten confirmation for this. They tell us they don't chase patients, but that's what they say. But this would be covered by CMS.
Okay. So it's part of this panel, room assured panel.
Yep. RheumAssure and Ident RA at Quest.
Okay.
I have a question.
Yes, go ahead.
I'm wondering, are you working on trying to see if perhaps it can predict any other than the some subset of SLE, any other arthritic disease, psoriatic arthritis, etc.?
Great question. So most of the research lies within rheumatoid arthritis. I can go over. So within SLE, most SLE patients will be mildly positive, but it does not have diagnostic sensitivity within SLE, except for identifying SLE patients that have secondary Sjogren's syndrome. So it can help positively identify just that specific subset within SLE. Within psoriatic arthritis, we have a little bit of data showing that patients that have patients that have erosive psoriatic arthritis will be positive. However, patients with just regular psoriatic arthritis will be mildly positive. So they kind of hover around the positivity rate being 0.2 nanogram per mil and above. So they may hover around 0.4 to 0.15. So that's the data. There's a lot more we can do here as well. But it seems to be, this biomarker seems to be specific for autoimmune conditions with joint involvement, as far as we can tell.
Okay, thank you.
So is it a protein? What is it exactly?
It is an intracellular protein. Typically works with trafficking and signal transduction.
Okay, and then is there anything that can alter the results or the contraindications to this test?
Not as far as I'm aware, in terms of treatment or therapies. Not that I'm aware of. So it is agnostic to treatment type. We've ran this looking at the response to treatment across various biologic and non-biologic DMARDs, and it has no effect on the veracity of the diagnosis and prognostic ability.
Okay, but after treatment protocols, these markers go down, or they disappear, or what happens to them?
So typically, if the treatment is working, the levels of this marker will drop or go negative. So those patients tend to do the best if they were positive and they become negative post-treatment.
Okay, Dr. Cruz asks, has the 14-3 eta been lowered with allografts, MSCs, mesenchymal cell?
So can it be lowered?
Yeah.
Was that the question?
Yeah. Mhm.
I am not sure about that. I can look into that and get back to Dr. Cruz if I can grab her contact information, if that's okay for me, Dr. Bill.
Fine. Ask Dr. Cruz. Sure, I got a sure here. So intra-articular or IV is a question mark. So I'm not sure what you mean, Dr. Cruz. So with that. So how long has this test been around?
Since 2014.
Hey, Dr. Clearfield, it's Rafael Cruz. What I'm asking is, has any, many of us have treated arthritic conditions, osteo versus rheumatoid, with amniotic products or umbilical cord stem cell products and improve the patient's condition. Some of us are reluctantly doing IV and, we know the FDA doesn't like it. Some of us are doing intra-articular. And what I'm wondering is if in this clinician's experience, we know we can improve people with these treatments, but has anybody documented that this great marker was also lowered through the use of an exosome product or a umbilical cord or amniotic product? And then, not only doing on intra-articular, but are these people who would benefit from getting IV, and maybe it hasn't been explored, but receiving IV exosomes or IV stem cells 3 times a year to keep, their inflammation level low, and of course to put them on an anti-inflammatory diet to, complement their results. So, and Dr. Nima probably hasn't explored that yet, but it would be very intriguing because there's rheumatoid arthritis patients who would say, sure, I'll, do IV stem cells 3 times a year if it's going to keep me from keep my rheumatoid arthritis from advancing to the point that I can no longer play tennis or, golf or whatever.
So to my knowledge, no one's really looked at that. There's no publications with those treatment outcomes, but it is a very interesting point that you brought up that I'll look into that, but to my knowledge, there's no research in that area.
Okay. Dr. Clearfield can probably take it on. He likes challenges.
Thanks a lot. I got enough regulatory agencies gunning for me. So, but thanks. I'll take that one on too. Okay. Anybody else have any other questions? You have just a brief sort of summary for us, Dr. Mazinani. Did I get that right? Just we sort of like okay, the take home. So
the take home is that the 14-3 eta biomarker can be used for the diagnosis, prognosis, and treatment monitoring in rheumatoid arthritis patients. So that's the takeaway. And again, if anyone wants to reach out, if they have any questions, you can jot down my contact information. I'd be happy to answer any questions and provide publications as well.
mm-hmm. So when you see a patient, do you do the rheumatoid factor and the anti-CCP 2 and the 14-3 test? You do all 3?
Correct. All 3 should be done at once during the diagnostic phase, as well as if you're going to run CRP for monitoring, 14-3 eta should be tagged along as well, ideally, to really identify these patients and stratify them.
do you ever get any conflicts, where yes, especially if you're monitoring a treatment protocol where your 14.3.3 is going up and the other two are going down? Then what?
So usually things are actually, so with anti-CCP and rheumatoid factor, they're not as modifiable as 14.3.3 eta. And so those levels typically don't move much during the course of treatment. And as far as I know, they're generally uncorrelated with 14.3.3 eta. But because 14.3.3 is a direct propagator of joint damage, I tend to rely more on those levels if it's really elevated to really understand what's going on the joint damage level.
Okay. I'm gonna see if Dr. Cruz again. Could you list the individual tests for workup? So do you have a protocol or what's in one of these panels here? Or is it just those three?
So it's you can an individual test for the workup. So you do, I think it'd be the Ident RA, or the RheumAssure would have anti-CCP or ACPA and RF, as well as I think they have a few IgA, IgG biomarkers. These panels both include 14.3 eta and the traditional rheumatoid arthritis biomarkers. So I rely on these, and then for monitoring, you just tag on every time you want to run a CRP, you want to tag on 14.3.3 eta as well. And especially if a patient is controlled, you want to do it intermittently and just identify if they're at risk for remission, a risk, for a flare while they're in remission, because on a lot of these biologics specifically can mask a lot of these symptoms, but really cover up the ongoing low-grade joint damage that occurs.
Okay, great. Okay, anybody, any other questions?
Hey, Bill.
Yes.
Hey, Dr. Am I coming through?
You are.
Mazinani, right?
Correct.
Hey, you've talked a lot about diagnostics, but you've been in it long enough to see the therapeutics. Since we're an open group here, I wonder if you have opinions on therapies, not just diagnostic, but the different therapies which might be the most useful. And do you ever look at the alternatives like the acupuncture, nutritional, homeopathic, any of these things?
So I think it depends patient to patient. But I think whatever makes the patient feel better, that's in line with functionality, lifestyle and activity works. Things like biologics, I think, is becoming more and more clear that they have long-term adverse effects that outweigh the short-term benefits potentially. So those are typically ideally reserved as a last resort to at least control disease and then offload them with other more homeopathic and lifestyle therapies. I think that's typically the course of action that should, be approached with.
Thank you.
Dr. Spear, are you out there? What's your opinion? I know you're out there. So those of you who don't know Dr. Spear, he's our senior rheumatologist. So he's on our list here, but he's usually pretty shy. So be interested to see what he has to say.
I'm here.
Okay. Do you have any experience with this?
No, I have not. This is nice and new and very usable.
I have a question.
Yes, go ahead.
What is the current dose of methotrexate for the treatment of difficult cases in rheumatoid arthritis?
I'm not sure about that one.
Well, Dr. Spear.
Well, I had a patient call me today to ask me for a refill of her methotrexate for rheumatoid arthritis because she couldn't find her doctor anywhere. And I didn't have her records. So I couldn't prescribe it.
Anybody?
Do you hear me?
You're a little blurry, but go ahead.
I mean, if somebody is on methotrexate and you haven't seen them and you don't have the blood parameters and they're asking to have a refill on a potentially dangerous medication, the answer would be no, you do not refill it if it's not an active patient of yours.
Exactly, I didn't. But
Good.
it was nice to know how is it used.
So I would take exception to that. I think that's a good rule of thumb, but you know, if the patient, you can call the pharmacy, find out what they were taking and give them a week or two. But I agree, if you don't have any relationship to the patient, it's different. But I've seen some people in an urgent care setting and I've bridged their situation. Even though I didn't have all their blood markers, I called the pharmacy, got what their previous dose was and gave them a week or two. You know, it's a little bit risky, but if you actually see the patient, they say, I've been on this stuff for a couple of years and it helps me and I just can't find a rheumatologist right now. I think you're not going to hurt somebody with 2 weeks of methotrexate if they've taken it for a few years. But ideally, you do have to have that patient relationship because otherwise there's too many hungry lawyers wanting to hurt us all. So
That's right. Thank you.
Okay. Anybody else? Questions, comments?
No, I have a kind of an interesting thing I'm doing tomorrow. I'm actually giving a speech in front of the Brevard legislative delegation. This is a delegation that will be going to the state legislature to be voting this. And I have a couple medical freedom topics I'll be talking to them about. I may
Which are?
well, I think I would like to give you all this quick 3-minute presentation because I actually haven't given it yet, and I have to give the speech tomorrow. So
You can practice here, Dr. Nima. Are we wrapped up here?
Yep, I'm all done here. Thank you so much for everyone's
All right.
time.
Thank you so much.
All right,
We
take care,
really
everyone.
appreciate your time and your expertise, and we're always happy to have you come back.
Fantastic. I really appreciate it. Have a good
Thank
night,
you.
everyone.
Okay, good night.
Thank you.
Okay, Stefan, the
I'm
floor is yours. Go ahead.
gonna time myself. What time do we have right now? Someone time me. Okay, I got
5:42.
All right, here we go. Over the past 3 years, the CDC and the FDA have demonstrated that they are failed institutions. Unfortunately, mayors, city councils, town managers, police, law enforcement, and the medical establishment across the nation and Florida have embraced medical tyranny while standing behind the gown of these 3-letter institutions and the cry of health emergency. I ask the legislature to put in place the following medical freedoms. 1, expanding right to try therapeutics. Number 1, right to try off-label medicines and non-FDA approved nutraceuticals and peptides for both patients in hospital and outpatients. 2, in the setting of psychiatry and chronic pain, legalizing marijuana and psychedelics, both as prescription and recreational use. On the next topic, expanding body autonomy for patients and removing medical tyranny and reducing healthcare time waste. 1, ban return to work or school pathogen testing. 2, ban doctor's notes for return to work or school. 3, ban medical buildings from preventing patients' families and visitors to stay by a patient's side. 4, disband any and all vaccine requirements or mask wearing requirements for employees of any setting, including medical. Disband these requirements also for students ages preschool through university. 5, ban establishments from barring entry based off of vaccine status or mask wearing status. 6, no discrimination based on vaccine status in schools, colleges, medical procedures, hospitalizations, or any surgeries, including transplants. 7, mandate complete, documented, informed consent for all childhood vaccines. On the topic of health and nutrition, decriminalize raw milk from grass-fed pasture-raised cows and increase access at commercial supermarkets. 2, require warning labels similar to the warnings required on cigarette packages for foods and menu items that use highly oxidized seed and vegetable oils. 3, prevent Bill Gates, China, BlackRock, and other large entities from buying farmland and homes in Florida. Encourage tax-free small farm homesteads that follow regenerative agriculture practices. 4, ban the use of glyphosate and Monsanto seeds in Florida. And in government post-pandemic topic, limit the power of mayors, city council, police, and sheriffs to close down businesses, bar people from beaches and public parks, or limit freedoms in any way for the sake of any public health emergencies. That's all.
We got about 2 minutes and 40 seconds.
That's good. I did it.
Well, that's quite a shopping list.
It is a shopping list. If they could just not ban raw milk, if they could legalize that, I'd be happy.
You know why they started to ban raw milk? It was because of outbreaks of tuberculosis, that you can get a systemic tuberculosis from it.
Yeah, I've been reading the book called The Untold Story of Milk. That's a very interesting story of how that myth got out there.
Oh, is that a myth?
It's a myth, and it's actually the tuberculosis found in that raw milk can actually not be transmitted to humans.
Well, that's interesting. I wonder where these people got the tuberculosis. That's an interesting question then.
Yeah, it was a lot of propaganda back in the 1930s, and it really stemmed from so back in the 1930s they had these whiskey swill mills. So they put these cows underneath the whiskey distillery and they fed them the slop. The slop was what the whiskey waste product was. So instead of throwing it away, they fed it to the cows. So these cows' milk, there was one, it was low quality milk, but two, they were standing in their own filth in these sweltering New York City stalls in the 1930s. So the cows were very sick. So they fed this milk to children throughout New York City and people. And well, they got sick. They got very sick. They got diarrhea illnesses. So they looked at it and they're like, oh, the milk is bad. We got to pasteurize it. Of course, you got to pasteurize sick cow milk.
Yes. Okay. Good point. Also, I was a teenager in the 60s, and looking back at that, and then looking back at meeting up with friends of mine who were recreational marijuana users on a regular basis, I found that they stepped into a time warp that they never stepped out of, and I found that troubling.
It is. Definitely, there's a problem with abusing drugs. We've heard lectures here of the benefits of psychedelics, marijuana. It's silly to ban it. It's just another overstep. I guess the government overreach, right? Same thing. They want to ban peptides. They want to ban N-acetylcysteine for, and then they go and approve Wegovy for children. It's craziness.
Also, bioidentical hormones, compounded hormones.
Yeah.
Can I give you an opinion?
Mm-hmm.
Sure.
So I think it is a pretty good list, but there is so much animus in the use of drugs and in the use of marijuana and psychedelics. Although I have your opinion, I share your opinions about it, that you have better chances to be successful if you just take that out and bring it in at a future date. Just have your laundry list approved first, and that would be really successful. Okay. And then at the second time, at second run around, bring the marijuana and the psychedelics.
Yeah, that's a good idea.
I want to tell you, I read your lecture before you just gave it, and I think it's phenomenal. And I disagree. I just read on Medscape an article about psilocybin that says that a psilocybin experience is treating treatment-resistant depression and PTSD far better than ketamine and holding people depression-free for 12 to 24 months. And we all know any product, whether it's raw milk, marijuana, too much of a good thing becomes bad. My sister does medical marijuana in New Jersey. She's been able to get she does family practice. She's gotten a ton of people to get off narcotics, and they maintain a job and a life and pay taxes, and they control their pain or their depression with medical marijuana. So I think the pendulum is shifting. And yes, anybody can abuse anything, including raw milk, to distraction. But to me, your list is phenomenal, and we need to beat that drum. I don't have the courage that you have to go public and say that, but the more of us, and I'm hoping to grow to your stature, but the more of us that get the courage to do that. I mean, I've seen ketamine transform lives, and, you know, there was tons of resistance against that. And, you know, yeah, I had a friend who was a pothead, and he had a college soccer scholarship, and he blew it because he just kept smoking pot. We all know it drives down your testosterone, or you lose your drive. So I forgot who that philosopher was, but every antidote becomes a poison when misused. And everything you've just said, we need to change this country's perspective. We live with a medical mafia that's suffocating people's freedom. We're living with medical tyranny. And, you know, until more and more of us get the courage to do what you're doing, you know, we're not going to impact the medicine as much as we could. But I think what you're doing is phenomenal, and I'm very proud of you for whatever that's worth. So
Appreciate it.
We've got some questions about whether we can get a copy of your lecture.
I can't see to paste it here.
What's that?
I can't paste it in the chat for some reason.
If you could email it to me, I can put it on the website if that's okay with you.
Sure.
You'll be fully acknowledged as the author and owner and all of that.
Well, yeah, I'll be on public news tomorrow.
Be tarred and feathered, maybe.
Yeah.
You'll be needing that string.
So how are you not afraid, you know, with all the crap that Dr. Clearfield's gone through, and, you know, Peter McCullough, Paul Merrick, all these guys, you know, what besides your faith in God or whatever, how are you getting the gumption to do what you're doing? Maybe that's too difficult a question, but I just have to ask you.
It's probably the way I was raised. I was always raised to question governments and, like, you know, stand up. You know, I've already ran for political office once at age 17. I ran for a city council. I grew up in Germany, and I was homeschooled in Germany, where it was actually illegal to do so. We did it every day because it was the right thing to do. We just kind of flew under the radar there and thwarted the German.
But you're not flying under the radar. You're saying,
no.
Fuck you, medical world of America. You know?
Yeah, I am.
And have you been hassled by any medical board or any other institutions?
No, I mean, I run a direct primary care. I don't take insurance, and kind of on the fringes already. And I, as I said earlier, I am working with the body, which is a parallel health system. And I think if this thing comes to fruition, it would embolden a lot of you to speak out more. If you knew that there is a separate credentialing system and a second licensure where you could still practice and help patients without having to kowtow to, you know, these people.
How close is that to becoming a reality, this new body thing?
It's starting up now. I mean, I'll be presenting a few lectures. There's going to be a couple other presenters. I mean, it's going to start out. That's the draw with this thing, bringing people in for the CME credits, like Category 1 CMA. Who doesn't want that? But then as it grows, the membership, they have a couple smart people behind this, And I think it'll definitely happen because they're going to be using, it sounds like the Native American system. So there's some sort of workaround there. But I'll support it. We'll see where it goes. I believe it might work.
We are actually still certified by the AMA to grant CME credits. We haven't lost that. It's just the AOA to throw us out. So,
That's
believe it or not.
surprising. I can't believe it. The AMA, they're the worst.
Yeah, well, we're right. As of today, we're still certified as a CME granting body. Right? And the person that I deal with at the AOA has been a good friend of mine, and not the rotten SOBs who threw us out. And speaking of which, one of the ringleaders has now resigned. He's now gone from CEO to he's now the went to Hospital Corporation of America to be back.
Typical.
Yeah. So,
So
speaking
Stefan,
of which, just to let you guys all know, in case you didn't see in the flyer, February 21st, we will have Peter McCullough. So tell your
awesome.
friends,
Wow.
tell your friends, tell your friends, tell your colleagues, tell your enemies.
Peter McCullough, February
Yeah,
21st.
we have, and he was at our conference last March, and so he's been a good friend to us. We're not that big a group. I would think somebody like him would say, well, I got better things to do. But he's never said no to me, which is, I don't bother him too often, but he's always said yes to me. So I'm
That's great. What's he going to talk about?
Well, tune in. We'll find out. What do you think he's going to talk about?
By the
So-
way, if I may mention one thing about Dr. McCulloch, we only had a crowd of maybe 20 in Las Vegas. The guy is so good-hearted and major and blessed by God. He flew in, he talked to us, but he had it figured out. Even though we only had 20 in the audience, he spread the lecture to 80,000 people that night. So he's way ahead of the game, or they would have buried him by now. And I have a specific question. Are you dealing with the Citizens Council for Health Freedom or another group?
No,
The
So
Citizens-
who are you talking to in front of?
it's the state representatives of the legislature, the Florida legislature. They will be there, and they are going to then bring our messages to the legislature to vote on next month.
Wow.
So you would probably have a better chance there than you would in, say, California, right?
Oh yeah. I don't know anything about Florida, California. I just know the patients that I'm seeing now, they're fleeing California. They're coming here.
So,
John, hey, John, I believe you were referring to Citizens Commissions on Human Rights out of Los Angeles, correct?
No,
Okay. They're pretty huge.
well, the group that Senator Ron Paul and Rand Paul have been supporting for what, 20 years, 30 years? What's the name of that group? I think it's the Health Freedom Coalition.
I'll
Not
look
sure.
it up.
Okay, but they were a primary with homeopathy.
Okay. The
So,
Citizens
Doc-
Commission on Human Rights out of Los Angeles, they're part of the, I forget the group. They're the ones that got the psychiatrists and psychology and big pharma to put the black warning labels on the pills and stuff. And then they've also debunked a lot of psychiatry and psychology as pseudoscience. It's really deep, how deep they get.
Our international ibogaine centers are now advertising for psilocybin weekends. So you spend 4 days on the beach for $3,900. So they're doing it offshore, but I have no idea what the rules and laws are here. So good luck, Dr. Hartman.
Hey, just PA Hartman.
So for Stefan and Dr. Clearfield, anybody wants to comment, how do you feel about using indigenous Indian medicine as protection for your license? And, if the board wants to go after you, and they take away your license, can you still practice it as a, pseudo Indian healer and be allowed to work, because I've heard these mechanisms being used by, you set up this organization, the patient joins your organization and pays $5 a visit or something like that. And then you pay the indigenous Indian group a percentage of that.
Mhm.
And that allows you to practice as part of the Indian nation. But how protective is that when our licenses are federally granted? And if they
Right.
take that away, can
So
you legally
what
work?
the
Because then
body
they're
is
gonna
doing, the body is creating their own certification process, their own CME, and their own network of clinics like mine, pharmacies, and hopefully eventually hospitals, right? So completely separate.
Hi, this is Dr. Cruz. So replying to Dr. Cruz's question, probably if you're gonna work under the auspices of the Indian nation, you're gonna have to practice on the physical grounds of the Indian nation, because that's how their laws work, and that's how you get the protection under their laws. So you can't say I'm practicing natural medicine under the auspices of this Indian reservation. They'll say, well, you're not on the Indian reservation, so any laws that you're trying to hide behind do not apply because you are not physically on
Indian
the
land.
correct. Yeah, so that's where you would get the protection, is being specifically on Indian land, because the Indian affairs have their own they have that protection against regular US law.
You know how Dan Royal does it? Because I think he's right in downtown Las Vegas. And he's got his turtle
Right.
his turtle
Maybe
band, whatever.
Is
Maybe-
it valid? He pitched his thing to me and it just didn't convince me. Are you part of the turtle band?
No, no, I've heard him, but no.
If someone really went after him, I think legally he may not
Wouldn't
have
hold.
a good leg to stand on. But this is where I'm going to stand on my bandwagon, is where we have to work for physician autonomy. So that, I think that's a great idea, creating our own your own licensure board. And then you're creating again, it's the creation of a standard of care. Create an organization and say, this is our standard of care. Because if we look at the AMA, the AOA is not covering the type of care or the type of medicine, medical treatments that we are offering, then as an organization, you can say, well, we are the standard. So no one else can say that they are the standard, because they don't even know what we're doing. So we are the standard of care, and then we hold everyone accountable to what we consider as our standard of care. So that's where you would get legal protection, and law-wise, it would be hard for someone else, the AMA or the AOA, to argue that, hey, you're not following the way we do standard of care, because they're not even doing what we're doing.
Excellent. Yeah.
Cool.
Well, Stefan, keep us informed, because I've always wanted to be a part of that kind of protection, but I've always felt like the turtle thing, and there's been several others.
Yeah,
wouldn't
I don't
hold
know.
water.
I don't really know much about that, and it's still developing. I mean, I would reach out to Michelle. I put her email there, and we can get a call together with Dr. Avery Jackson. He can explain it better than I can.
Okay, great. Well, thank you again for having the courage to do this, because it's going to take a lot of us. And, when we see you doing it, of course, Florida is the best state, but I think you and DeSantis and all those guys are going to gradually start transforming this country. And that's what we need, because we're in a tough situation.
Yeah.
So great job.
Appreciate it. Cool.
Okay, thank you. Anybody else? So there's a Citizens Commission on Human Rights. There's a email link there. Next week we have Felice Gersh, Dr. Felice Gersh, who's one of our great, hormone specialists, and she gave me her topic, and I don't have it right at my fingertips. But she's always entertaining. She's always really informative. My schedule, I've been keeping it on my phone, blew out, so I sort of lost some of it. So I have Kathleen O'Neill Smith for the week after that, but apparently she's not going to be here. So it might be somebody else. I'm not sure. We have Dr. Andrew Campbell coming up, Dr. Pam Smith, Dr. Benoit Tano, and then Peter McCullough. That's in the next month.
Cool.
So you don't want to miss it. You'll learn a lot. All of those folks, you'll pay a lot of money to go to A4M or AMMG, whatnot, to listen to, and you get them here for free. So one of these days I'll figure out how to do CME credits, for these Tuesday nights without a whole lot of hassle, and then we'll be even better. So, well, it's a little early, but anybody else have anything they want to add, John?
Everything's great. I was
Doing
just
well.
thinking, after saying that our main ibogaine source in the Bahamas is doing the psilocybin, it's important to note that we also have a structural regenerative clinic with stem cells and exosomes on another island in the Caribbean. And they have an investigational review board, and they're doing some really top level stuff. So what our group might do to keep our research going, but at the same time be totally legal, we might want to join that group. And I want to discuss that with you, Bill, and anyone else who wants to go with it.
Mm-hmm. Also, okay, and next week, from Wednesday to Saturday in South Lake Tahoe, if you're in the area, where Nevada Osteopathic Medical Association has their winter conference. I'll be doing a whole day. I haven't decided yet. One of my topics that I've been working on is 40 years as an anti-aging physician. What do I know that the AMA and AOA doesn't? So that may be a topic. So I'm also working on methylene blue. I know, those of you I needed to summarize it because there's just too much information from Dr. Halassa, not in any order. So we'll probably be doing that also. If there's interest in getting together and doing a live conference somewhere, or even a weekend Zoom kind of thing, let me know. Like I said, we're still AMA certified, and I can probably work with the Nevada Osteopathic Medical Association to get DO credits if those are needed. So maybe in the summer, maybe we can get together somewhere. And I've sort of been taking it a little bit easy. The drive to get because this would be our time to be gearing up. Kind of when the air kind of went out of the tires there. So, but maybe in the summertime we can, if there's interest, let me know. To meet in person.
Yeah, why not go to the Bahamas?
So I was thinking more of the peppermill, but that's okay. We've been there before.
When are you going to give your lecture, the things that I know that the AMA and the AOA doesn't? Because I would be very interested in that, including purchasing it from you.
Okay,
If
well,
that's what it.
I'm still working on it, so it's not done yet, but I'm doing like an A to Z. So I'll probably get A to C will probably be that's about as far as I'll get in a whole day. So I'll do it. We'll do some of them here.
Great.
I'm not hiding anything. I just want to make sure that everything's the way it should be. So my A's, just as example, so I have adrenal fatigue, I have anxiety, and then autism. So those are my A topics. And my B topic is battlefield acupuncture. So I don't know if that's of an interest. It's kind of the things that that I've just been making notes of the things that we do that when students come in, they've never heard of it. So, okay. And somebody, Dr. Souther's got a doctor from Old Forge, Pennsylvania, where my old stomping ground where I used to live. So, so give her my email. So to have her join us, we'd be more than happy to have somebody from Northeast Pennsylvania. Let's see, somebody wants, what is my website? Is that Dr. Berger? Is that what you want? My website?
Yes, yes.
No, it's drclearfield.net. Okay.
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 Thank
It needs some work. So like everything else. Okay. So we're going to let you go home a little bit or leave a little bit early tonight, if that's okay. And like I said, next week, Dr. Felice Gersh, if you're in the area, South Lake Tahoe, it's also being live streamed. So you can go to the NOMA website, Nevada Osteopathic Medical Association, and you can do it online. Anybody else? John?
All good.
Okay. The other Dr. Cruz back there, that's who I thought I was talking to in the chat. Good to see you again. And Raphael, thank you always for your help. And everybody, we've got a couple of new names here. Dr. Thelmusa is a new name I'm not familiar with. And Claudia, of course, has been here for a couple of weeks now, and Dr. Dell, and of course, Dr. Patel and Dr. Blanchard, Dr. Stone. So thank you all, and and Dr. iPhone, the mysterious iPhone. So thank you all for helping, being with us. Bring a friend, bring one friend, and we'll have twice the audience. And we'll see you again next week, same time, same station, 5 o'clock. The video will be up as soon as within 24 to 48 hours. And hopefully we can get Dr. or PA Hartman's talk. If he sends it to me, we'll get that also. Okay.
Hey, Bill. Hey, Bill.
What's that?
I was just letting you know, I'm Jenny. I'm from WVSOM. I graduated with WVSOM. I'm the psychiatrist from New Jersey. You and John and I talked a lot about lots of advanced medicine and medicine that most doctors, I'm crazy. That's okay. I'm crazy in my area, so.
Well, we're sort of the misfits here, so welcome aboard.
So I just wanted to let you know who I was.
Okay, and so in case you missed it, last summer we were decertified after 50 years. So, I just haven't gotten around to getting us recertified, as integrative medicine. Although we are actually an official IRS in the state of Nevada recognized nonprofit educational entity. So, so I'm not so sure I want to actually at this point, and then have to deal with those people again. So, and if anybody else wants to, let me know. So, well, thank you for being here. And if you have anything to present to us, please do. I said I have endless Tuesdays to fill up. So.
Dr. Clearfield, one last thing. Are you posting these lectures on your website? Where do we go?
On aosrd.org/webinar.
Can you text that to us?
.org/webinars. Okay. They're always on there. They're usually within 48 hours they're up. There's over 2 years worth of almost every one of the lectures we've done. We've been doing this for over 2 years now. Are there. Some of them have the transcripts on them. Some of them have the slideshow also. So, but they're all there. Okay.
Excellent. Outstanding. Thank you.
Okay. So, anybody else, any questions? There's my email address, drbill9@gmail.com. You can always get me. I'm here every Tuesday. And anybody else, Anybody else who wants to present anything, please let us know. Like I said, we're booked up until probably April, although January 24th, I'm not sure who I have. You may get my lecture then. I don't know. Let's see if I got nobody. So,
Hey,
So-
I just want to say something about what you brought about semaglutide and B6 and BP 157. My sister, as I said, is a family doc, and she's had 3 men on Ozempic, 50 or 60 years old,
Mhm.
who have become extremely emotionally labile, depressed, anxious. I don't know if anybody's seeing that with pharmaceutical dosing of Ozempic or Wegovy or whatever it's called. And she's like, I've seen this 3 times in the last 3 months. I'm very reluctant to use this medicine now. And I said, well, you should do it like Dr. Clearfield does.
Yeah, we haven't had that. I've also had somebody call me and tell another doctor call me and tell me that they're seeing pancreatitis with
Right.
with the semaglutide. And again, I haven't seen that either. So we get very few patients who can't tolerate it, and it's less than 3% of our patients.
So my point
Novo
is,
Nordisk rate is 44%. So
the point is that once again, you figured out a way to do it better than Big Pharma and the AMA and the AOA, a safer, better weight loss, less side effects, and
Yeah,
lower dosing.
We haven't been able to get the raw material for tirpirazide though. Is that how you spell it? Say it. Morgiano is tirpirazide,
Right.
which is a combination of a GLP-1 and I forget what the other thing is. It's supposed to be even more effective. So, so if we can get that raw powder, I think we'd probably do even better. But on average, our females lose about a half a pound a day on average, and our guys lose about 1 pound to 1.5 pounds. Our guys lose 30 pounds in a month. Not hungry and not doing well, and so it does seem to stop working after a while if you use it continuously. So you sort of have to pulse it. So
Are you doing a month on, a month off?
I do like so the way we mix it up, it comes as a 5-week dose. So we'll give them 10 weeks on, and we'll give them 2 to 4 weeks off, and then if they need to keep going, we'll re-up. And I don't think I've had anybody use more than four rounds. They seem to lose enough weight, and then the challenge, of course, is having to keep it off. And so we're working on it. We're getting better at it. In fact, AMMGs has me. I'm going to be speaking about the new facial weight loss. Did I do that for you guys? I think I did it for Dr. Halas's group. So AMMGs asked me to come in Miami to do that. So I'll be doing that.
Right.
I think that's in April. So sometime. So with that, tooted our own horn here. Dr. Hartman, or PA Hartman, always brings us good stuff. We're still watching. We're still interacting with Mr. Gonzalez in Spain on the prostate program. And I'll tell you, just as a personal thing, I've been using it myself, and I ran out of the lactoferrin, and the symptoms came back just on ivermectin. And when I got the lactoferrin back, it went back to where it was. So maybe it's just the lactoferrin. You don't need the ivermectin. I don't know.
Maybe.
So,
Try raw milk too.
huh?
Try raw milk. Let me know.
I've got 2 prostate cancer patients on ivermectin only. For whatever reason, they didn't want to add lactoferrin. One guy was peeing 5 times a night, and after 2 months, he's down to once a night. He's 70, and he's treating himself, strictly natural. And the other guy's pretty much the same thing, an executive in his 70s, still very vigorous and working. So just ivermectin is helping 2 prostate patients. But once again, I didn't join the network. I'm experimenting with my cancer patients, but I want to get to the point where I don't feel like, I'm on the list as an investigator. And then,
We'll run
you know,
the-
they,
Just send me your cases. I'll put into my part 2 that I'm putting together.
Mhm.
okay.
Don't
You
worry,
just-
we'll
you
run,
want-
we'll run interference for you. We won't let anything happen to you.
Okay. So what do you want from me? Literally the case history and a made up name, or what,
Yeah.
what information?
Probably
Yeah,
just
you
use
give me-
initials.
The case history and tell me what's been going on. The PSA changed everything, you know, whatever your documentation is, just send it my way. I'll put it in my PowerPoint.
Okay. I'm still waiting for their symptoms are better, but they haven't repeated their PSA. Both of them are like 2 or 3 months into their ivermectin course. But when I get the repeat PSA, definitely forward it your way. But
Yep.
just ivermectin. So some people probably need the lactoferrin, and it's even better. But even ivermectin alone is impacting people. And again, very few docs have the, you know, the courage. I have a little bravery, but not nearly as much as you guys. But, you know, they tell me, you know, I've called all the doctors in my city and none of them will give me ivermectin for my cancer. And you, Stefan, inspired me and the guy from Spain, I'm from Spain, to do this. And I was nervous, but I said, shit, I owe it to these people because your presentation and his was so compelling. And just the first 2 guys I try it on, it works.
Yeah,
I mean, it's just mind blowing.
it's a very low number needed to treat.
Yeah, well, but I'm giving you my, you know, what little I can give, but
Great.
it's great. I mean,
you know-
it's mind blowing, you know? So, yeah. Anyway, thank you both, all of you, and especially you, Dr. Clearfield.
Thank you. I mean, there's, you know, I've looked it up. There's PubMed literature on using ivermectin and lactoferrin for prostate issues. And, you know, so it's not, you know, you're not flying, you know, blind that you just made it up. There's actually studies that have been published and whatnot. So, you know, you just have to go find them. So.
Yeah, but I mean, remember, there's like, what, 70 studies of ivermectin treating COVID successfully. And, you know, we're still, some of us being attacked for prescribing ivermectin for COVID. So, but I'm definitely going to keep trying to grow in courage through you guys.
Well, I order all my ivermectin through Amex Pharmacy, then I don't have a problem. Nobody says a word. Somebody says boo.
Right. I'm using Amex too. Good.
So,
Okay.
you know, he makes it into a whatever dose you want, you know, lozenge, you know, they only have to take 1 a day. And, you know, that it works out fine. I think he charges $4 a dose. So it's not inexpensive, but it's not terrible.
Right.
Okay. You can get it from India for 15 cents a pill. If you're brave enough to, you know, do that, this is what you get. These are 12 milligram. I don't know. Can you see that? It's 12 milligrams of ivermectin. It's made by an Indian company. So I don't know if you can see that on.
I can see it. Which company are you ordering that from? Can you text that to us?
I just went to indiamart.com and you type in you want ivermectin and 25 people will call you. Each one will give you a better price than the last one. I think I paid $155 for 1,000 of them with shipping. So it's made by the Lancer company.
So what is your perspective? Is it illegal to buy a medication from India? Because I hear yes and
I'm
no.
not dispensing it to any patients. This is for home
Okay.
use.
There is another place called All Day Chemist online,
Okay.
24/7, that can mail anywhere.
Yeah.
No prescription required.
So
Wow.
yeah,
Thank
so
you.
I'm not
All
giving,
Day Chemist.
like I said, I'm not giving this out to any patients. This was for home use. Any patients, I usually just go through Amex. You know, they have to do all the whatever paperwork the pharmacies need to do. So. Okay.
Thank you both. Yep.
All right. So now that we've hung ourselves, now we have this on film. That's So we'll send this one to the AOA next. John. All right. Anybody else want to stick their neck out while we're at it? So, okay. Maybe iPhone here is, we're the government spy. We never don't know who that is. So
Yeah, who is that?
That might be me, Bill.
you?
Yeah, I have my iPhone on too.
Okay. Okay.
So if
All
you
right.
don't see my name separately, that's me.
Well, maybe you are the government spy. I don't know.
Hey, I'm here giving advice.
Yeah, you see where we're at. So, all right, we're losing our audience. It's getting late. We'll see you again next week, same time, same station. Dr. Gersh will be here. She's usually a few minutes late, so I usually do a little song and dance about 15 minutes before she comes on, but she will be here. So thank you, everybody. Everything will be up on our website as soon as I get it done, and we'll talk to you all soon.
Thank you, Bill.
Thank you. Thank you, Dr. Cruz, the other Dr. Cruz, and everybody else.
Thank you.